So thank you, everybody, for joining us for the Ask the Experts on Bowel Management for Parents and Caregivers. My name is Juanita Panliner, and I'm with the Spina Bifida Association's National Resource Center. And we can move on to the next slide. And thrilled to be able to introduce our bowel management experts for this evening. We have Heather Dories. She is the mother of a 9-year-old boy with spina bifida, and she's also the admin of the Spina Bifida Parenting Support Group on Facebook, and she's a parent advocate for special education services in Florida. And Eileen Sherborne has been a nurse at Children's Wisconsin since 1989. She's currently the nurse scientist for the Spina Bifida program with a special interest in bowel management. Eileen is a member of the Spina Bifida Wisconsin Board of Directors, and she was also a member of the Lifespan Bowel Management Protocol Development Team. Colleen Payne is the mother of a teen with spina bifida and is a co-admin for the Bowel Management for Spina Bifida Facebook group. She is trained as a rehabilitation counselor and also serves on the board of the Spina Bifida Association of Kentucky. And we also have, did we have also a slide with a QR code for something that we're going to be using a lot of? There we go. Yay. So do you have your copy of the Lifespan Bowel Management Protocol? We have a QR code here so that you can download your copy. And also in the chat, we'll be putting a link to where you can go to our website to download it. And there is also a link that will also go in the chat for a session that was done in June 23 that shows you how you can use the protocol. And then at the very end of today's session, if you want to stay just a couple of extra minutes to watch a brief video demonstration of how you can download your copy on a mobile device. And just a couple more housekeeping notes before we get started. As you probably heard when you were joining, we are recording the session, and so that everybody, so that people that were not able to join us tonight can also watch it. And everyone who registered for the session will receive a recording as well as a Q&A document of this. And we want to thank everybody who submitted so many questions in advance, and we certainly hope that we're going to be able to get to them all tonight. And because we have a lot of questions, in the interest of time, we ask you that you please remain muted, but please feel free to submit other questions in the chat. And so let's go ahead and get started. And with this, I'd like to introduce or turn it over to our first expert, Eileen Sherborne.
So thanks for being with us, everyone. We're really excited to share our collective knowledge and experience tonight. I just wanted to kind of kick us off with some fundamental concepts of bowel management that I've experienced through my years of working with families and children and adults with spina bifida. When children are born, we hear parents say that the baby is peeing and pooping normally when the baby is still in the NICU, which is important. But the concept to consider is that there's changes resulting from spina bifida that may not be immediately obvious. And we expect babies to be incontinent or, not have any control. But we don't expect babies to poop continuously. We don't expect anyone to poop continuously. But as the babies develop, parents notice that the poop never stops coming out. So that's what we're really trying to set an understanding of as the baby and children develop. And that lack of control is because the rectal sphincter, which helps us control pooping, isn't really innervated properly. So therefore, most people with spina bifida need a bowel management program to both prevent constipation and promote continence. And the second kind of concept stems from the first. Not only do we want to prevent constipation, but promote continence. And this really takes time. And in my experience, I really try and encourage a bowel management, a bowel intervention about the time the child is 2 to 3 years old. We're already working on preventing constipation in infants, and we'll get into that with more of the Q&A. But the road to bowel continence takes time, often several months. And We really encourage children to be continent on a bowel management program before preschool or 4K, and that can take months. And plus, kids at this age, if we can get that younger, they tend to normalize bowel management rather than starting a program when a child may be 5 or 6, and it might be a little bit more difficult to get them to, I don't want to say cooperate, but be able to tolerate a bowel management program. It's just a different way of pooping when we work with kids who are younger. And then the third concept really stems from the previous concepts, that we really want to start from a least invasive to a more invasive intervention. And if the lesser intervention is not successful, then we move to the next step. So we really start with oral medications and then move to rectal interventions to empty that rectal vault. And my experience also is if we use these least invasive to more invasive interventions, that it really can build trust, that we don't start with something that's very invasive to start out, unless the person is older. And we know that oral medications aren't as successful as other interventions. So, yeah, that's kind of some beginning thoughts. And then we wanted to include bowel management providers because, well, I'm lucky because I'm in a Spina Bifida clinic with awesome providers. But, you know, how do I find a doctor who has experience and knowledge treating neurogenic bowel? And certainly you can ask your state organization, state Spina Bifida organization, or your local children's hospitals if there is one. And you really want them to be familiar with Spina Bifida. So you want to make sure you ask that question as well. What's the best way to find a gastroenterologist? Again, that's also through your local Spina Bifida chapter. Also, you know, I think that families share a lot of information. So if you know other families who have had success with certain providers, that word of mouth is also reasonable. And yeah, through Spina Bifida Association or your local children's hospital. So this person is having a hard time having a bowel movement neurologically, and do they need to see a neurologist? So we do call it neurogenic bowel. And you may think that you need to see a neurologist, but really the providers who manage bowels, for the most part in pediatrics, is the urologist, with some involvement from the GI specialists. And in my experience with adults, the providers who can manage bowel programs in the adult are really the physical medicine and rehabilitation specialists and the GI specialists. And with how do you manage digestion with Spina Bifida? That really would be more of a gastroenterologist if there's actually something wrong with, or some challenges with eating or that type of thing. And then our GI is a gastroenterologist. It actually means gastrointestinal, but it's the specialty doctor is a gastroenterologist. And our most Spina Bifida patients followed by a GI or a gastroenterologist doctor. And for the most part, I really would have to say no. The kids, we have about 200 children in our clinic, and I would say there are a few that are followed by a GI doctor, but for the most part, it's urology that's managing the bowels. And Colleen would add to this, but Kelly, why don't you add what you were saying about, you know, for families who are really in rural areas or don't have the access to the specialists that we do, perhaps in a large city?
Yeah, there's some parts of the country where you're just not going to find a doctor who has experience treating neurogenic bowel. And so in those situations, it's really helpful to connect to the community and for us to learn from each other. And then, as it says there at the bottom, share the protocol that we've been sharing with you with your provider. You can print it out, you can send them a link. You can show it to them when you're in the office, and they, I'm sure, would be happy to know that there's a protocol in place for this.
The one thing I might add to that is, because it's a really lengthy document, you might just want to print out what's appropriate for your aged child. Just having spent the week at a bowel camp for kids with inflammatory bowel disease and working with the gastroenterology doctors there, it's like, and I did that for an infant also, is just shared the specific age group, because so that's a nice part of the bowel management protocol.
Yes.
So Colleen, I think that's
Heather.
Yes. So dealing with constipation, one of the questions we got was, what are the best ways to manage constipation in kids with SB? So this is going to differ depending on what age you're talking about. I'll say if you're talking about a child continence age. So as Eileen was saying, ideally that would be before they enter school. For those kids, really an effective enema program is going to be the best bet for managing constipation. Now, when we're looking at babies and toddlers, really at that point, management looks like preventing constipation, because normally when you start introducing solids, it can happen before as well. But in that time, you start seeing a change from constant stooling to hardening, and then going the opposite end of the spectrum with constipation. And so you are using oral medications, rectal medications, to try to keep this nice fine balance, not teeter-totter to one extreme or the other. And that's kind of the game you play until you're ready to move on to an effective enema program. But a lot of times when you're looking at how to work with that with babies and toddlers, you can look at something to soften the poop, and then also something to help stimulate the bowels to then remove that poop. So when we're talking about a softener, that would be something like Miralax or lactulose. If we're looking at a stimulant or pusher, that would be Senna, X-Lax, can be a daily suppository, the little liquid glycerin bulb suppositories. Those are amazing. So that would, when you're looking at the baby and toddler age, that's really mostly what you're going to see with management and prevention of constipation. And then the safest and most effective way to unblock. So when I hear block, I think of that rectal vault at the very end. There, your baby's uncomfortable, your toddler's uncomfortable, you're struggling. So at that point, oral medication isn't necessarily going to help right at that bottom. That's going to help the stuff that's still forming in the top. So really, when you're talking about unblocking, you really want to go towards rectal interventions at that point. That's going to be your quickest way to see help, to get relief. So that's going to look like liquid glycerin suppositories. I just mentioned enemies. You can do fleet enemas, not daily. That it's not safe to do those daily, but that could be done. And also just digital rectal sweeps with a glove. You can do that as well. One little parent anecdote that I love to tell parents is, get yourself a box or two of those Pedialax liquid glycerin suppositories, little bulbs. But those things can be pricey. Instead of buying a new box every time you run out, you can get a bulk gallon of glycerin on Amazon and just refill those yourself. And really, in the long run, with how much those things are used, you save yourself a lot of money by cleaning them and refilling them yourself. So we'll mention those suppositories a lot. So every time you hear that, just remember, it's much cheaper to just DIY that later on and keep the bulb. And then as far as unblocking, once you're on a bowel program, that looks different. And that goes more towards bowel clean out. And then I'm going to throw that to Colleen to start talking about what a bowel clean out is.
So just for some terms that we use, some people call just their regular daily enema, their clean out, their wash out, their flush. So just so we get all on the same term, when we talk about a clean out, we're talking about cleaning out your bowel because of constipation or to get ready to start a program. So this is a screenshot from the lifespan bowel management protocol. And so what we want to do here is answer questions, but also point you to where you can find the answers. And so this is in Appendix 2, and this is one of the best appendices of the whole protocol, probably because it gives so much detail about how to do a clean out. So before you start an enema program, I really encourage everyone to do a full clean out top to bottom. Doesn't matter if the kid's been on Miralax for years. Doesn't matter if they're not constipated. It's just, if you do a good clean out before starting the enema program, it's going to be much more effective and much more comfortable for them. And we want those first few enemas to go really, really well so the kid doesn't mind it. And so recommend doing a full clean out, like prepping for a colonoscopy style clean out before starting a bowel program. And then there's more to this. Let's see. No, so on the next page of the protocol there's also partial clean out. So let's say you're on a cone enema program, the kid gets constipated and you want to make the solution more effective. We're going to talk about that in a minute. Then before you do that, do a little partial clean out, because we don't want to make the enema solution stronger on a constipated belly. It's going to be very uncomfortable. So what a partial clean out is like doing your enema program 2 a day for 2 days, morning and night. Sometimes one thing that I like to do is add Miralax in the morning enema, along with whatever else you put in it, 1 to 3 capfuls. And then at night to add half of a fleet enema, or a whole one if it's a big kid, and to do that 2 days in a row. And that's a pretty good clean out to get you reset. And then of course there are hospital inpatient clean outs, and we try to avoid those because they're pretty traumatic and just messy and expensive. And so by being really proactive and aggressive at home, we can avoid those inpatient cleanouts.
So here are a few more questions that came in. We've tried enemas, stool softeners, and Miralax, and either they make my son have accidents or they don't work at all. Is there something different he could take to help him keep regular and avoid being so constipated? Looking at this, my first thought was babies and toddlers, that's pretty normal. But because I see the word accident in there, it makes me think this is coming from a parent of maybe an older child. So my first question would then be, is there a daily program that's already in place, a daily enema program, or, what's the routine daily? If not already on a daily program, then I would look at that Appendix 1, least to most invasive that Eileen showed earlier, where you're starting with oral medications, then suppositories, then enemas, then large volume enemas. So looking at this question, it seems like oral is not working, suppositories not working. It says enema in here. I don't know if you mean like a fleet enema or a large volume. If you've already moved on to a large volume enema and that's not working, I would say we need to look at the ingredients that you have in that flush and make some adjustments to that, just make it stronger. And that's probably what the issue is. Flush ingredients need to change over time. It's not a stagnant thing where what you get started on is going to be that way for the rest of your life. As a child gets older and bigger, and things can change. So, and the only other thing I can think of is when I'm seeing Miralax in here, if the child is on a large volume enema, like a cone enema, daily, and also doing Miralax, that can cause a problem. Adding Miralax into a routine, if you're already on a daily flush, can actually kind of sabotage continence a little bit. So be careful, because that's very common to have accidents in between with that. Next question is, my 7-year-old gets constipated all the time despite his high water intake. I do bowel wash in the evening because doing it before school is very challenging. He uses 1 sachet a day of Movicol. It's like Miralax, for those that don't know what that word is. Once the stool is loose, he dirties himself all the time. Okay, it's going to be very similar to the last question, where you need to work on what the solution is to just make it more effective. Doing bowel wash in the evening or morning is fine, but yeah, just reading through the question again to make sure I cover it all. Yeah, time of day is completely fine, but also if you're doing Miralax on top of that, again, right back to Miralax can mess with the bowel program once you have one in place, unless there's constipation happening and you're using it, like Colleen mentioned earlier, as a clean out, partial or full. A lot of times Miralax can cause more problems. So I'd say the best bet is to try to DC that Miralax and tinker with the solution to just make it a little bit stronger. And Colleen is going to talk about the additives and things you can do. Actually, right now, look at that. There's
My segue.
the bottom too. What a perfect segue.
Heidi asks if it's okay to perform an enema every day. Yes, it is, except for a fleet phosphate sodium enema, and those are not safe to do long-term daily. But if you're doing a homemade enema, yes, it is safe to do them daily. A bowel wash is the same thing as an enema. Again, we have different terminology. A lot of times people in the UK call them washouts, and that's what it sounds like because of the Movicol instead of Miralax. So yes, you can do a daily enema. Some people do it every other day, but I would say most do daily. So what are all the possible solutions and products for the incontinence problem? So you saw the least to most invasive, but when we're talking about a continence program, so bowel programs start from infancy with just keeping things soft and not stretching out the bowel. But when we're talking about a continence program, which we can call like a big girl, big boy bowel program, then there are different types of enemas that we mostly use. So some people use an enemies. It's a very small enema. These are less effective. They're effective for some, but not the majority of people. We have the fleet enemas, the sodium phosphate enemas. Again, these can be used for like when there's constipation, or occasionally we need to add a little extra oomph to an enema, but you wouldn't want to use these long-term daily because they're not good for people who have kidney issues, and they can cause the bowel to get really agitated and restrict over time. Bulb syringe enemas is one thing we can do for babies and toddlers. If we want to get them stooling less often, we can use a little nose sucker, and that can be a good first enema. There's also balloon enemas, and what this is a 24 French Foley catheter that is silicone, not latex. And we hook up a bag of fluids to it, insert the catheter into the rectum, inflate the catheter, let the fluids go through the catheter, and then that balloon at the end, it blocks the water from coming back out of the rectum. There's also a cone enema, which is really common. And instead of inflating a balloon in the rectum, there is a cone that you hold in the rectum to keep it from all the fluids from coming out. There are transanal irrigation, which most people know is Peristeen or Navina. And these are, you have a bag of fluids, you pump water into the rectum. Again, there's a small balloon in there. And then there are antegrade enemas, which are the surgical solutions. The MACE and the cecostomy are the two big ones. I think we're going to talk more about that later. And then, of course, there are colostomies. So those are possible solutions. And we're also going to talk about products and how we can tweak the solution for the MACE. So let's talk about what you put in an enema. So this can go for a cone enema, and it can also go for a mace. I like to say it doesn't necessarily matter how you give the enema, whether it's from the bottom up or the top down. The solution is going to be about the same. The difference is Peristeen. Peristeen's a little different. They recommend just using water, and it defies all logic when we're talking about enemas. So that's completely different. But if you're doing a cone or balloon or mace, then some possible ingredients that you can put in there. The base will be either water or saline. Some people prefer saline, especially if their kid is just kind of chronically dehydrated all the time, because saline is more like your natural body fluids, and your colon is less likely to suck up all that water, making it less effective. So some people use tap water, some people use saline. Best not to use well water or a water softener. Then we have additives. So it used to be back in the old days, a surgeon would just do the mace and then tell somebody to keep increasing the water until it was effective. And people were putting like 2 liters of water through their colon. And that started to stretch things out. And so what we found in recent years is that instead of making the volume of the solution higher, we make it stronger. And so for toddlers and preschoolers, sometimes the first enema, parents will add a little squirt of baby soap. The reason baby soap, like Johnson & Johnson baby wash, is effective is because it has some glycerin in it. So that's a really easy, cheap ingredient to add just to give it a little extra stimulation. Then next, a really common one is glycerin. So glycerin, you can find little bottles in Walmart or Walgreens or whatever, and then you can also buy them by the gallon, which is what us old pros do, because it's much cheaper. And then glycerin sort of like lubricates the stool and stimulates a little bit. And so it's very flexible. And so most people start at like 20 mLs of glycerin-ish, could be less, could be more. And then you kind of keep increasing that until you don't like it, it's not effective or whatever. And then the next stronger option is usually Castile soap. And so people start with 10-ish mLs at a time, again, increasing until it's effective. Some other additives that people use. So Castile soap is very much a stimulant. It just kind of irritates things to get it pushing. Sometimes people put Miralax in the enema solution instead of taking it orally. It doesn't make any sense why that works to me, but it does. It kind of flushes things out. Sometimes it works a little too well and you get accidents later on. Some people use Thocalax. Some people, there are different things, and you can put some things on the in the chat. Unfortunately, I can't put the list on the screen right now, but it is in the Appendix 7, Enema Basics. So when you want to tweak the solution for the mace, basically you don't want to keep increasing the water usually. You want to add additives to make the solution stronger instead of higher volume. Great, thanks, Heather.
I will add, for the most part, the low volume enemas are what 2 of our other colleagues use most frequently. It's 30 milliliters of glycerin followed by 60 cc's of warm water. And that's usually pretty successful for people.
And for us, for my son, he uses like 400 mLs of saline, and then he uses a bunch of glycerin and Castile soap. So these smaller volume typically work better than the using 1500 mLs of saline. So next question, we just started using the balloon enema. My son is having issues keeping in the full volume of the liquid solution. He either poops out the balloon or starts leaking around 125 mLs. Any suggestion? Yes. So with the balloon enema, again, you're using a 24 French Foley catheter, and the balloon, it's a 30 cc balloon. Okay. So if you blow it up to 30 cc, it's going to be pretty small. And for people with spina bifida who have looser anal sphincter tone, then it's just going to pop right out. But the kind of the secret to that is that you can actually increase that balloon higher. So when we use them, we use anywhere between 45 to 60 cc's of air. You can put water in it. Some people use up to 80 cc's. So that balloon can actually get a lot bigger, and that helps it stay in. The other reason why the balloon might pop out or start leaking is you got to be sure to do a clean out before you start the balloon enema program. It's going to be more comfortable. It's going to be more effective. It's going to leak less. And when would you suggest a bowel boot camp? Is this for everyone? There are some children's hospitals across the country that have what they call bowel boot camps. And that's where you go for like 10 days. It's outpatient. And every day they do an x-ray, they tweak your solution until you have a pretty effective solution by the end of the week. We've done this before, my son and I have. I would say bowel boot camps are good for people who, if you have one close by you and you have the time, then sure, why not? If you have been really struggling with an enema solution, you feel like you've tried everything for a long time and you're like, I'm ready to give up. If you can get to a bowel boot camp, sometimes that can be helpful. And they can, in a very short amount of time, tweak your enema solution. They do typically balloon enemas, Peristeen, maze solutions. So I don't think it's necessary for everyone. Most people can get a pretty good solution using their local provider and maybe some other moms and just some trial and error. If you want to get it going fast, a boot camp is great for that. When doing a cone enema routine, how do you know when to remove the cone? So you put the cone into the booty, you let the fluid flow in, and then usually people hold in the cone for 5 to 10 minutes. And that just helps everything loosen up inside. It can make the cone enema more effective. Sometimes kids are not going to cooperate with that. Either it's a little kid and they're real wiggly and they're not going to sit very still for that long, and then they're just getting poop water all over you. So you don't have to do it that long. You might need to make the enema solution a little bit stronger if that's the case. If they're very uncomfortable when you're holding the cone in, it may be that they're constipated. And again, remember, we need a clean out before we get started. And in that first month or two of a program, it's very common to get constipated. And so you do a reset and you get going again with a more effective solution. What amount of solution should be used for the cone enema? There's a little bit of science and a little bit of art to this. So a standard thing a lot of people say is 10 to 20 ml per kilogram the child weighs. So us Americans tend to translate that to about 10 mLs per pound to get started. I would say that's a little bit on the high side, but let's say you have a 30-pound child and you want to start with 300 mLs of water or saline. That's a fine place to start. Once you get up to about 500 mLs, like a more than 50-pound child, you could just try 500 mLs. Like Eileen said, some of the people on the protocol that helped make it use much less, like 60 mLs. So there are a couple of like rules like that help us out to get started. As far as like how much glycerin do I use per pound, there's no real rule about that. You start with 15 to 30 and you increase it until it works. And so for some people, they don't need glycerin at all. And some people need a whole bunch of glycerin and then Castile soap and other things. It just depends on their particular colon. Anything to add to that, guys?
I'm going to pop in because there was a question that came up earlier when we were talking about enemas, specifically for blockage and clearing out. And it was, what is the safe daily enema? So really the not safe daily enema is fleet. Enemas can talk about enemies, which are smaller, or we're talking about large volumes here, which is more what you think of as a daily management cone enema, balloon, and then transanal irrigation with the Peristeen Navina. So there's two kind of separate categories there. But when we're talking about clearing out and for constipation, those types of enemas, you can use the liquid glycerin suppositories, which aren't technically enemas, but can function like that. You can use those daily, multiple times a day, actually. Colleen, is it 3? Is that like up to 3 times a day?
That's what my pediatrician said. You can use these.
That's the rule.
3 a day. So that's the rule now.
But really, Fleet is the one that you do not want to use as daily management.
And you don't want to use more than 1 per 24 hours. So if you're going to use Fleets to help unblock, then you can do it like 2 nights in a row, but not morning and night.
Yeah.
Okay.
The Fleet enema has phosphate in it, and that's the problematic electrolyte that can cause electrolyte disturbance, which is why we're giving you all these kind of side information on the typical Fleet, which is also why you need to read the label on the enema to make sure of what you're giving, because there are some Fleet that are simply saline, and that's okay. But if it has electrolytes in it, then you need to be careful.
And I said earlier that I couldn't put the additives up on the screen, but I could. They're really so
I think we got the order a little wrong. I'm sorry, Colleen.
I know.
Just one other thing about glycerin is I don't know if you'd really want to go higher than 60 to 70 without having some support through your provider.
Also,
as you're increasing.
Have you seen people use a Fleet enema through a cecostomy? Sure. If my son was constipated and I wanted to do a reset, partial clean out, then he might add Miralax to his morning enema, add a Fleet enema to his night enema, and do that for 2 days. But again, you wouldn't want to use a Fleet enema daily, every single day. Second, just a little tip. Don't add Fleet enema and Miralax in the same solution, because it makes a really chalky like liquid, and it's going to ruin your bag, and you got to throw away the bag. So that's something
and grody. Yeah, it's not a great combination.
Okay, Eileen, what about laxatives?
So for long-term stimulant laxatives, they are very effective and can be one of the fundamental interventions on the least invasive hierarchy. And we tend to use these in the littler kids who, again, we want to go least invasive to see, well, what can we be most successful with again, preventing constipation and promoting continence. So often you may be able to time a stimulant laxative so that the child has a bowel movement at a certain time outside of school or daycare or that type of thing. But I really have not experienced any long-term difficulty or challenges with using stimulants daily, even in more so the infant and the toddler group. Because as we move into preschoolers and school-age kids, we really are moving towards a rectal intervention. Although there are some kids who do have innervation and do have some sensation and may need a stimulant laxative maybe once a week or a couple times a week, and that is also appropriate because that's how we're really achieving our goals for bowel management. And then our glycerin suppository is a good alternative to stimulant laxatives. So yes, they are. And again, we're trying to find that balance so that the baby isn't pooping all the time, because that really leads to some bad skin breakdown. So you can really go kind of up and down with stimulant laxatives as well as Miralax to find that balance for your child. And the glycerin suppositories are quite effective. I can't remember if it was Colleen or Heather that talked about, buying the big gallon and then saving the little gourd introducers. There's about a teaspoon or 5 milliliters in that glycerin suppository. And generally, you're not be able to get all the fluid in there because, the baby's laying down, and I guess you have to hold the butt cheeks together because we find the liquid to be more effective than the solid suppository. And it's also works faster if you use the liquid suppository. But you do have to hold the cheeks together to let the glycerin kind of irritate the lining of the rectal vault to make it empty. And it usually works fairly quickly. I would say, within, 5 to 10 minutes or so. Also, parents have found, as well as nurses, that sometimes if you insert a thermometer or that little Frida baby windy thing, that can also help infants poop. But again, that rectal sphincter tends to be loose. So some of these need a little help. Also in the protocol, there's directions for how to do a digital rectal sweep, because that can help empty the rectal vault also.
Great.
So any suggestions for non-surgical interventions for bowel management? Absolutely. And truthfully, I believe most doctors that do the surgeries really prefer parents to have started with something else beforehand. Some don't, but from the majority that I've heard and spoken to, they really like to leave the surgical options as for when they get older, or just if you've tried the another program and it hasn't worked. But so when we're be a broken record here, I apologize, but we're talking about cone enemas, balloon enemas, Peristeen, Navina. Those are going to be your non-surgical options. And again, will be found in Appendix 7, Colleen. Is that the Enema Basics one? Would have the different types in there. So yeah, I'm partial to the cone enema because you don't need a script. You can go on Amazon. You could go on tonight and order the stuff you needed and be ready to start by the beginning of the week. So beginning of next week, for it all to come in. So I like not needing to rely on anybody else to send in scripts and wait for insurance to approve and all that. So yes, there absolutely are non-surgical interventions for bowel management.
We're going to talk a little bit about Peristeen here. I'm going to switch order to the third one. We're thinking about switching to Peristeen. Any reason? Oh, I'm so sorry. That's my bad. Second. Any reason to stay with the cone and not switch? Okay, so there are pros and cons to both. So like Heather was saying, with the cone, you can buy it on Amazon or other places. You don't necessarily need a script. You can get a script and get it from a DME company. So it's a low barrier to entry and it's fairly inexpensive. I think you can get a cone enema kit for, what do you think? $60. And that'll last you forever. So it's not like you use a different one every day. So that's what's great about the cone. And but the con is that it can be difficult to do it independently. And so it usually requires someone to hold it in, whether that's a caregiver. I've seen some people make a strap to put across the toilet so that they can do it more independently, but it can be a little difficult. So for Peristeen, there are a couple of big benefits. One is that it is more likely to be done independently. The independence rates are higher for Peristeen. And the second thing is it can take less time. So some people do it in a half an hour instead of an hour every night. And it takes longer for other people, but those are two main benefits. Then the con would be, does your insurance pay for it? Can you find a DME supplier that will supply it for you? You do need training from someone who has been trained to do it, and you need a prescription. So you're jumping through the hoops for the DME. So for some people that is completely prohibitive, like they can't get anywhere with it. For us, it took a year to get approved. But for people who can get it approved and paid for, then it can be a great thing to try to see if they can be independent with it. The next question is, my daughter's 17 and wants to go to a big college when she graduates high school. We use Peristeen, which has been great, but she can't do it by herself. Any thoughts or ideas for independence besides surgical? Okay, so Peristeen, is made to be done independently. There are some people who can't do it independently. And it usually involves when the balloon for the peristine won't stay in the rectum. And so you have to hold it in. So for somebody with balance issues, with someone with short arms, there are lots of reasons why this can be really difficult. So thoughts or ideas for independence, it would depend on what the actual barrier is. So if it is balance, you might get a bedside commode, remove the bucket, put it over the toilet, and that could be used for some balancing. If it's that she can't clean herself up afterwards because she can't see, she can't feel, then some people use a bidet. And so you can also ask an OT. You can get an OT evaluation and see if somebody can kind of walk you through these things. You can ask other parents for how their kids do it. It takes a lot of creativity to kind of figure that out. If it's not possible, then we have a decision to make here. And so as teens get older and become adults, sometimes they have to make a choice. Do I prefer to be completely independent and have accidents every now and then? Or do I prefer to be completely continent and need help with something? So sometimes there's a choice to make. Hopefully we don't have to make a choice between those two, but sometimes we just have to let the teen make that decision for themselves. So let's say she decides, you know what, I can't do peristine on my own, but I could give myself a suppository every night. And every now and then I will get backed up and it's not going to work. But for the most part, it does work and I'll be able to go to college. So that's a potential solution. It does say besides surgical here, but I'll just make a note that usually if someone can't do the peristine independently, the next stop is surgical. So the MACE and the cecostomy are two surgical options that Eileen's going to talk about in a minute. Really, I think these surgeries get a bad rep because most people do the blue plate special and get Mitrofanoff, bladder augment, MACE, the whole thing at the same time. And that is a very difficult recovery. If somebody is only going to get the MACE or the cecostomy, it's actually not that bad. It can be done, well, I say not that bad, but of course that's relative. It can be done laparoscopically, it can be done robotically, and the cecostomy in particular is less invasive. So it's worth asking what all the surgical options are.
And I just want to pop in really quick. I don't know if Eileen is going to mention this in hers, so I apologize if I'm stepping on your slides, but really that 17-year-old, 18-year-old right about to go into college, that really is the time that you want to talk with your teen about surgery, because if you put it off too long, you might have a hard time finding a doctor willing to do it. So just kind of keep that as part in the back of your mind. If very against surgery, okay, absolutely. But if it needs to be a part of the conversation, don't put it off too long, just because you will have a harder time finding someone that would agree to do it after a certain age.
Or who knows what it is for adult providers.
And to pop in, my son had cecostomy. We're going on like 5 or 6 years with it, and it was probably one of the easiest surgeries he's ever done. So just to give my own little anecdotal stuff in there, it really was not a bad surgery and recovery. Can't speak to the MACE or the blue plate special, obviously, but if you're just looking for bowel management and looking at that, it's not horrible.
A little easier, yeah. And the next one, just quickly, my son is 14, started peristine last year. He can't hold in the inflated catheter. Again, we have a looser rectum. We usually do it deflated, sometimes inflate and deflate throughout, trying to hold the water in, but I have to manually hold it in. Yes, sometimes, and I would say more than you would think, people have to manually hold it in. And so there are a couple things to try. You can, there are adult-sized catheters, there are child-sized catheters. Some people say inflate the balloon bigger to help it stay in. Some people say inflate it smaller to help it stay in. So there are lots of little things to try to talk to your provider about to help see how well we can get it to stay in. But if not, yes, there are people who use peristine and they manually hold it in. So Heather, what about insurance coverage?
Insurance. That's a fun one. So people do struggle sometimes to get coverage. And for us, that's one of the reasons that we did not even consider Peristeen, because my husband is a contractor and his insurance changes a lot. We're going to have coverage. We know we'd have insurance, but we don't know if in 6 months it's going to be the same insurance or a different insurance. And so we had to just keep that in our minds when we were considering this and thinking, all right, this is going to be a problem, because every time we switch, we're going to need to get this approved again. So for us, that was one of the reasons that we didn't really consider Peristeen or Navina for our kiddo. But as far as insurance, it can be challenging to get them to cover it. The first thing I always say is advocate, push hard. If you can, ask your doctor to fill out an appeal. You can contact insurance and also explain why you're wanting this for your child. Really advocate. You are your child's best advocate. For most people, it is just not going to be possible to pay out of pocket. You're looking at about $1,500 for the system, and then you're looking at around the same per month for the catheters. Now, there are some people that wash and reuse those catheters. Not necessarily recommended, but people do it. But for most people, I just don't think that that's going to be a possible amount to spend per month. But if you are able to do that, a lot of times you can talk to Coloplast, and they will help you find a DME company that can get it for a little bit less. But again, if you're looking at $1,500, a little bit less is not going to bring it down to like $50 and we'll call it good. So in more cases than not, if you've done everything with advocating and asking your doctor to appeal and appealing the appeal and doing all of those things, odds are it's time to look at a different solution, like a cone, or potentially talking about surgeries, things like that.
I have heard that potentially the Navina, which is newer in the US, it's been around for a while, other places, but that it may be cheaper. So I don't know that for sure.
Two things I just want to add on to that previous slide was the 17-year-old who's going to college. When you do the college visit, you really need to work with the college to find out what kind of assistance they can give so that she can be as independent as possible. And yeah, that's really important from a transition standpoint. And then, prior to Wisconsin Medicaid approving Peristeen, we had a lot of success just by appealing. I know that can be frustrating, but we did have success with appealing any insurance refusal for it. And then Foley catheter is actually a urinary catheter with a balloon on the end of it that there's a certain amount of fluid, saline or water, that you can put into the balloon, although it can tolerate a lot more water, and it can tend to, what you do is you blow up the balloon once you insert the catheter into the rectum to help hold the enema fluid in the rectum. It has success for some people, and others it pops out. So it's worth it to give it a try to see if it can help. So we're talking really long, and we have like 7 minutes left. So I'm going to try and go through this reasonably quickly because we still have a lot of questions to answer. So bowel management surgery not recommended as an adult. It's not that it's not recommended, it's that you're going to have a hard time finding somebody, because it's the pediatric urologists who tend to do the surgery for the cecostomy and the antegrade continent enema, or the Malone procedure. So that's really what the issue is, unless the patient is moving towards a colostomy, and certainly the adult general surgeons know how to do a colostomy. Child who's had the Malone procedure, expect in the teenage and adult years, there should still be problems, but one of the issues with spina bifida is the weight gain and the difficulty accessing it, and then the increase in the abdominal fat that may make that channel difficult to stretch. So trying to maintain a reasonable weight is important. And that otherwise it should be okay, but yeah, it's just making sure that the appendix, the piece of material that's usually used to make that little channel. So this boy continues to leak from the stoma. There are some little buttons that you can put in there if that's the problem. I wonder if the child isn't constipated, to make sure that there's no leaking that way. And then another one of our colleagues mentioned that perhaps a revision to the MACE stoma might be helpful. So whoever put the MACE in, you might want to go back to the provider. I've seen that happen a reasonable amount. And then this bowel stimulator, it's actually a sacral nerve stimulator. And, you know, I looked up quite a bit of the literature. I haven't seen it done. I don't think it's real successful in people with spina bifida. You have to do a 2-week trial, and wires get inserted to the sacral nerve. And then there's a handheld controller to stimulate the sacral nerve. But I think that with the neural placode, the part of the spine that's outside of the body when the baby's born, or even with the prenatal surgery, that nerve isn't in the best of health. So I think that that's one of the reasons that the sacral nerve stimulator may not be as helpful in people with spina bifida.
And
Ellie,
we found that,
surgical. Sorry. Were you going to ask the question?
Go ahead, Heather.
Sorry, we had a surgical question come in, so I wanted to throw it to Eileen before she finished up that slide talking about surgery options. And that was just, when do patients get colostomy or ileostomy?
Oh, so that usually tends to be in the early adult years. And honestly, when I talk with people, actually people who've had with spina bifida, and this was at the World Congress most recently, is that sometimes that colostomy can be life-changing for people, as well as a cecostomy or ACE Malone, as well as any bowel program. Honestly, what we really want you to take away is we've got answers for you, and we've got lots of different kinds of things that we really want to try and help people with, and help your providers who may not be familiar with bowel management programs.
And then another question is, have you heard of issues with cecostomy flushes and vasovagal responses? If you don't mind, I'm gonna respond to that, since my kiddo has a cecostomy and we also deal with vagal responses. So there is a section, Juanita, if you're able to pull it up and let us know, it's in the appendices. There's a complications page, and it specifically mentions vagal response. It doesn't say it as vagal response, it does the full medical name for it. But as far as from my own experience with that, it's normally one of two things. It's normally either my son is constipated and we need to adjust his flush and make it stronger, so there's stuff backed up in there and the pressure from it being stuck makes him feel very sick, or two, dehydration. Especially in the summer, he gets dehydrated very easily, and we notice if he's not constantly drinking throughout the day, he'll really struggle with that. Other things that can cause it would be the temperature of your flush. You could adjust that too, but it is in the appendix. I know Juanita will pop in and let us know the page on that at some point.
Defecation.
Is that defecation syncope?
Yes.
Yes.
Okay, hold on a second. Page coming up.
So yeah, there's a whole paragraph in there with all the different reasons, but just from my own personal experience, it is almost always constipation or dehydration or some combination of the two. If it's the summertime, it's almost always dehydration.
And I think it happens more often than we realize, unfortunately. So we need to ask about it so we can try and help.
There's also some tips in there as well in that appendix with ways to, page 86 of the protocol, as far as like getting the circulation back in your hands and feet, can really help with passing that
And if there are people who don't know what that means, the vasovagal response or the defecation syncope, it's when a child is getting an enema and they suddenly might get a very strong headache. They might get sick. They might throw up. They just feel really awful. They turn pale. And it's just that the body is usually feeling pain from the constipation.
It's terrifying, especially the first time, and a lot of parents are ready to like call 911 kind of a deal. So it's important to know that it doesn't happen all the time, but it is a possibility. So just kind of be aware. Oh, Juanita put copy and paste right in there. So with what the symptoms are. So it is something that can happen, and just try tweaking some things to prevent it.
Next up, how to clean out so to have fewer accidents when coughing or sneezing. And this is what's great about those rectal interventions, that instead of, if we use oral laxatives, especially the osmotic laxatives, the softeners, the stool gets so soft that it's just going to come out anytime someone is coughing or sneezing because they don't have good rectal tone. And so it's often a lot better to make the enema solution stronger so you can use less of an oral softener. And then the next is also, does excessive coughing while on the toilet increase the chances for a rectum prolapse? In the same section as defecation syncope in the appendices, we also talk about rectum prolapse. It's where the inside of the rectum is coming out of the body. Typically, almost always, this is due to constipation. And so we would want to do a good clean out and then start again with a better solution. Excessive coughing shouldn't, I haven't heard of that before, not to say that it can't, but typically with a prolapse, you're looking at constipation. That's Heather. Can bowel function change or decrease as you age?
Absolutely. So there's many different reasons that it can change, but of course you can think of the more concerning ones, like tethered cord can affect bowel and bladder, but even things like mobility changes, walking versus if you're sitting down and you're in a chair more often, the more sedentary you are, weight changing as you grow. Really, it's bowel management is not okay, day one, this is going to work and this is always going to work. It can work for years, and then all of a sudden you start struggling and need to tweak some things, or it can take a while to get your system down right. Yes, and sometimes it's just as simple as tweaking the flush. Other times, I even in the adult section, I believe the adult asked the experts when I was watching that. Someone was saying, they had a mace that worked great for years and years, and then all of a sudden it just wasn't working anymore for them, and they had to move on to a different type of intervention. So, the easiest would be just changing your additives, but it's not unheard of to need to just completely change to something different if it's no longer working.
What about timing for bowel movement control?
Yeah, so this is, I gotta be honest, I don't like it. Every time I see anybody say, oh, we're gonna try time sitting. For me, time sitting or time, doing timing it's a great way to introduce the concept of sitting on the potty for longer periods of time, getting your child used to sitting there and having to be in the bathroom for, an hour, and you can work up to that. But as far as it being effective, that is going to be for a very, very, very small minority of people with spina bifida. So bowel control, it requires a lot of things. There's multiple components to it. So you need motility. So things moving through, you need feeling to know when you need to go. And then you need sphincter control to be able to open and close, release, all that. So there's multiple components. And if any of those are missing or slightly damaged, that can impact your continence. So for most people, if let's say you can feel when you need to use the bathroom. For most people, that would mean that you're pretty constipated to be able to feel that stool in there. And then to be able to try to have access to the bathroom in time, hold, release, it requires a lot of steps, and there cannot be any room for error in that and not, having an accident. So when we look at this for kids who are already going to have a hard time communicating all the ins and outs of what they can feel, what they can control, if you're looking at time sitting as a bowel management solution, I don't really consider that a solution, but I do think it's a good thing to introduce it. And one of the things we talked about when we presented the protocol is you want to make that those first steps, if it's time sitting and sitting on the potty and increasing time, you want to make that an exciting thing. You want to make it great. You want to reward them, not necessarily for using the bathroom while they're sitting there, but for sitting, and you're praising them for the act of sitting there and not the success behind it, I guess would be how I would word it. So yeah, the short answer is I don't think it's possible, but I suppose that there's probably like a handful of people out there that might be able to. But yeah,
there are some families who are successful with timed sitting, but what we recommend is not trying it for too long, so that you kind of have to have all your ducks in a row, making sure the child isn't constipated and their poop isn't too loose and that type of thing. But we recommend kind of reevaluating after 2 weeks.
and that's with all of the interventions. Was Eileen had the list from least to most, is really, if something's not working after 2 weeks, it's time to try something else and work your way through.
How do we help young children navigate school and peers when wearing pull-ups and not having control over bowel movements? I have a granddaughter who turned 6 today, going into the 1st grade. So this hits home to me because this is about the time that we started a bowel program. Now, in the protocol, we would like to start bowel management at 6 months old and have a continence program before we start school. That's even better, but not all of us get there that quickly. And so the first time somebody made fun of my kid for wearing a pull-up, we said, that's it. We're done playing around with trying to potty train the old-fashioned way. We're going to get this going. And so we started an enema program, which was immediately successful. And he could move out of pull-ups. Now, some people still prefer to wear a pull-up just in case, and they feel better like that. But he was able to move to an incontinence pad in underwear, and then eventually move out of that once we got the bladder stuff down. But so enema program, and actually school's going to start here in about 3 weeks, longer for some people. You could actually start a bowel program before school starts. You could get on Amazon, order your cone enema kit, start your clean out tomorrow. By the time you get your kit in, they're cleaned out, and you start your program, and they could be continent before school starts. It might not be perfect. It could take a while to perfect it, but it's going to be better than nothing.
And in the appendices, there's a nice list of other products like potty seats that are recommended for cone enemas. And so really, if you have a question on, okay, I want to order this tonight, you can find out all that information.
How often do laxatives need to be used per week? My daughter misses numerous school days, which affects her anxiety. And that is very true for most people with spina bifida, that incontinence adds so much anxiety to their day-to-day, which is why we recommend doing a very proactive, routine, consistent bowel program. Laxatives, if going to be used, like let's say you're going to use Miralax, a teaspoon daily to kind of keep things soft to go along with your enema, they need to be used every day. Pretty much. Some people go every other day, but it can take up to 3 days for Miralax to work. So you wouldn't want to give Miralax only on the days that you're seeing problems, because the problems have already occurred, and as we've said before, when you're on an enema program, if you're taking laxatives, it can sabotage continence.
Antibiotics and probiotics. So how to deal with poop when taking antibiotics? Yes, they do wreak havoc on the gut. You can try some probiotics, which also is in the appendix. Culturel is the one I'm most familiar with. I was talking to a gastroenterologist. He was talking about a probiotic called Align. And then there's Gerber Soothe for the infants. One of the things I learned from Colleen is you can do the enema program twice a day, right? Isn't that sometimes what you'll recommend so that there are less
Go in all the
accidents?
time. Mm.
And then what kind of probiotics should you give to a 1-year-old? You know, you can always start with food, regular food, certainly fruits and vegetables without any added sugar. Those always have awesome probiotics in it. And then, like I mentioned, the Gerber Soothe is probably good for a 1-year-old. And then cultural, you have to read the label because they have a ton of different products. But I have seen a lot of families go with the cultural product as well.
And just an added thing to that is, like, if you start giving a probiotic to a 1-year-old, that's great. Probiotics are great for gut health for just everybody. It's not necessarily a bowel program, and it wouldn't be like a replacement for something like Miralax, but it's a good thing to do. Whoops. Eileen?
How can I manage skin breakdown around my newborn's bottom? So definitely, I don't know. I think I'm a proponent of the Pediatric suppository, so the baby isn't passing multiple stools. And then also going up or down on the, if the child is on a stimulant laxative or lactulose or something like that, figuring out what is the right amount so that there isn't continual stool. Barrier creams aren't helping her heal. So there are specifics to barrier creams, and actually there's creams and ointments, and it's the ointments that are better, and probably ointment with zinc oxide in it. So again, you need to look at the labels. And often I find that it's the barrier creams that have worked on other children in your family. So we don't really recommend a specific barrier cream, although I do think that you should put it on as thick as cream cheese and then not wipe it off for 24 hours. So even when you're changing, if there's a little bit of poop on the barrier cream, just try and leave it there. Try not to get too freaked out about it, because if that barrier cream is there, then it's protecting the skin. Yeah, so that's, and then if the child's skin is really raw, maybe doing something like a little Aveeno bath to the butt once a day, and then you can get the rest of that barrier cream off as well. And I think that, and then also looking at the pH of any type of soap product that you're using, you want a neutral pH. So baby skin, or all of our skin tends to be a little bit more acidic. So Johnson's product usually are pH balanced, but you have to look. And Dove soap is a pH of 6, so that's also a good product. Yeah, thank you.
There are 2 questions about fiber supplements. So someone asked, is it beneficial to take a fiber supplement if you only consume 50 to 60 ounces of water per day? And are daily fiber pills okay for a teen with spina bifida and neurogenic bowels that are not always consistent? So glad you asked, because in this protocol, we talk about fiber quite a bit. And so the general thing is fiber-rich foods are great, okay? So they're good for everyone. Adding fiber gets tricky when you're dealing with a neurogenic bowel. So the colon wants to suck up fluid, right? And that's what it's doing. That's its whole job. And so when you add fiber to the stool, that bulks up the stool. However, it's not moving because we don't have good motility. So it's not moving as well. And it just sits there and it bulks up and it turns into a brick, especially if you're not drinking enough water per day. So fluid intake is extremely important to any bowel program. And I know kids are really terrible about drinking water, but it can just make it so much harder. So we got to try to figure out how to get fluids in them as best we can. Fiber supplements, whether it's a fiber gummy or a fiber pill, is probably going to cause more problems instead of helping. So especially a lot of people get constipated and then they take fiber supplements. and that's a disaster because it's going to bulk things up more. So if you did want to start more fiber rich foods on someone who is constipated, if a kid's constipated, you think I want to add more fiber to their food, clean them out first, increase the fiber foods that they eat, also increase their water intake at the same time. Careful with fiber. Heather?
Okay. Last question is, are there in-person workshops, in-service trainings for new parents and caregivers to help them establish and maintain bladder bowel continence goals via best practices and methodologies from a psychosocial and medical perspective? The reality is that a lot of providers don't know much about neurogenic bowels. Outside of major children's hospitals, you're just standard pediatrician or even GI, they just don't know. And so it's one of the reasons that this protocol was developed, was originally for medical providers to be able to send this to them so that really any doctor can, if they have a patient with spina bifida, can pull this up and learn best practices. So this is kind of the guide for that. And then we decided that it really needed to also be shared with parents as well, because we need to know what to advocate for if we come across a doctor that, like my son's pediatrician when he was a baby, that just will give him apple juice and that'll take care of it. For a typical baby, sure, but to be able, so as parents, to be able to advocate for our kids and send this to providers. So let me go back to the question, make sure I'm addressing this. So in-person workshops and service trainings, this is kind of that. There are bowel boot camps that Colleen had mentioned before, but unless your next one, and that really is going to be more for the older age kids, right, Colleen, versus, babies. Mm-hmm. And yeah, one of the things as far as psychosocial and best practices, one of the things that SBA has done through polling people with spina bifida and asking about their quality of life, bowel and bladder is one of those things that consistently comes out on top as things that they struggle with, and can really impact things like joy and your employment and things like that. So we're learning as time goes on that this is really something that the earlier we can address it, the better off, because it just becomes part of their daily life. It's all they've known their whole life is bowel management of some form or another. And so the earlier we can get in and make those changes, but this is one of the, I don't want to say it's new, but when you're looking at spina bifida and care and best practices, this is one of the newer kind of initiatives, is really putting the focus on this and saying this is very important. And it's important to speak with others that have SB and are on some type of program, whether that's through my group or Colleen's bowel management. I think just about every support group out there, the second there's a group question, Colleen's group gets tagged in it. So really up until this protocol, that was where a lot of people got their information from, was just one parent talking to another in support groups. So this is just kind of another step within that to take it further and get more eyes on it and have it just become more common. All right. So like I said, that's the last question. I don't think I see any other child related. Someone had suggested their son is going into 3rd grade and does still wear pull-ups because he has loose stool sometimes, but they also put underwear on top of it to hide the pull-ups. So that's a really good suggestion. I know we were just doing questions, but I thought that was great. If your child is one of those kids that really wants to wear underwear to school, which is completely understandable, that might be a really good option. So if you have any additional questions, please email Juanita with National Resource Center. Her email address is listed on the screen, JPANLENER r@sbaa.org. There's a phone number there as well. So if there's any questions we haven't addressed, you can go ahead and send them to her there. And then if you're still around and you haven't had a chance to download your protocol guide yet, I'm going to show you a really quick video. We're going to open it and just show you how simple it is to download this. So the first thing you would be doing would be going to spinabifidassociation.org. Let the video load. Okay, so we're on that website right now. You can see that. You're going to go to the research tab and scroll until you find the lifespan bowel management protocol. And then it's going to ask you to enter your information, name, address. Really, this is so that we can update you if there are changes made to it. We can make sure you're aware that there's new changes to it. So enter your information on the screen. And then once you submit that, it's going to let you click on download PDF. Now you can download this to your computer if you're doing it from there. For me personally, I did this on my phone and I saved it on my phone as its own icon. So whenever I am trying to remember a certain thing, I can just go right to it and it's up on my phone. The very second page is your full table of contents to show you where everything is. Really, with us doing this presentation, it was so important to us to not only answer the questions that you guys had, but to also try to direct you back to where you can find it in the protocol, because you're not always going to have someone there that's able to answer questions. And so we want to show you how this works and how if all of a sudden something just comes into your mind, you're like, I know exactly where I can go to get that answer and just pull it up. So even if you don't have any questions right now, go ahead and download that guide on your computer or your phone and just scroll through, play around with it. Like I said, you're going to start with that table of contents, then it breaks down kind of by age, just general what you should be looking at by age. And then the meat and bones, and my favorite part is the appendices at the end, where just anything you can imagine with different types of systems and additives and recommendations and complications and all this different charts. It's all in there, and it just really is easy to navigate around. I think I speak for all of us when I say we're really proud of how this turned out. It's phenomenal. And so thank you guys so much for attending, and I hope you enjoyed it. I hope you were able to learn something from it. Again, if you have any questions, email Juanita, and we hope you all have a great night.
Thank you.
To everyone.
Thank you so much.